webinar series. Our webinar today will discuss managing survivorship for adolescents and young adults who have been diagnosed with a pediatric brain tumor. My name is Crystal Ward. I'm a program manager here at the American Brain Tumor Association, and I'm delighted to introduce our speakers today, Dr. Goldman and Dr. Rychek. Dr. Stuart Goldman is the Medical Director of Neuro-Oncology and the Gus Foundation Chair of Neuro-Oncology at the Ann and Robert H. Lurie Children's Hospital of Chicago. He is one of the principal investigators of the NCI-supported Pediatric Brain Tumor Consortium, the Children's Oncology Group Developmental Therapeutics Consortium, and active in the Collaborative and Ependymoma Research Network, as well as the DoD-supported NF Treatment Consortium. Dr. Jennifer Rychek is the director of the STAR Long-Term Survivor Program, as well as the Adolescent Young Adult Oncology Program at the Ann and Robert H. Lurie Children's Hospital of Chicago. She is actively involved in the Children's Oncology Group, Survivorship, and Adolescent Young Adult Committees, as well as the Critical Mass Young Adult Alliance. Dr. Rychek's research interests include adolescent young adult clinical and psychosocial outcomes. Thank you so much for joining us, Dr. Goldman and Dr. Rychek. You may now begin your presentation.
Before I turn this over to Jen, I wanted to just make a special thank you to Dr. Elizabeth Wells, who has shared many of the slides and given us to show today, and we really appreciate your input. And I'm really excited to share this podium with a very fast pace. We have a lot of slides to go through discussion about survivorship, as Dr. Rychek has taken over our long-term survivor program with their history in social work. She's really in a unique position to really make a difference in the lives of the children we follow. Jen?
Thank you very much, Sue. So thank you for attending our webinar. We're delighted to have you. This was just a little cartoon to get you in the mood. We are very, very funny people, but we're going to be serious about this topic. So the objectives for this webinar today are to recognize the late effects that are associated with treatment for brain tumors, to identify those special circumstances for the population we're talking about, the adolescent and young adult brain tumor survivors, and to also identify issues that are about transition to adult care for adolescent and young adult brain tumor survivors. So who are survivors? 1 in 450 adolescents in the United States is a survivor of a pediatric cancer. That makes about 220,000 total survivors of pediatric cancer in the USA at this time. About 75% of all children diagnosed with pediatric cancer will be survivors, and 1 in 2,000 adults alive right now were survivors of childhood cancer, and those are statistics from 2000. We expect that there are more than that at this time. Most common pediatric cancer diagnoses include ALL, brain tumors, and Wilms tumor. Brain tumors, however, are the most common diagnosis and are more common than ALL per the SEER data. And the SEER is a data management situation that tracks all diagnoses in the United States and survival rates. However, the mortality for children with brain tumors is still higher than the mortality for children who are diagnosed with ALL or acute lymphoblastic leukemia. So what are late effects? Late effects are any physiologic or psychosocial problem that comes up after cancer treatment is finished that can be attributed to the treatment itself, chemotherapy, radiation, surgery, or the disease process that necessitated the treatment. Late effects also include potential problems that are screened for on an annual basis. So even though somebody does not suffer from a particular late effect, if it's potential late effect, we talk about those as well. Potential problems are identified based on the complications that we know of somebody's treatment, and screening is standardized through the Children's Oncology Group for all survivors. So we sort of talked about the survivorship population, but let's talk about late effects in the adolescent young adult population. So 1 in 250 young adults aged 15 to 45 will be a cancer survivor. And at least 50% of these people are likely to have or develop disabilities that alter their quality of life. So this clearly is a subject on which we need research and attention paid. CNS tumors or brain tumors pose additional challenges for survivors. And in the population of survivors of childhood cancer, 2/3 of those survivors will likely experience a late effect from their treatment. And again, a late effect is any outcome, either chronic or late occurring, that has occurred after treatment. So we define that as 5 years from diagnosis or 2 years from stem cell transplant, and it's attributable to the treatment. However, with all this being said, 89% of survivors still report that they are in good health. So what factors influence late effects? The age at the time of diagnosis, the tumor type and the location of the tumor, the cumulative chemotherapy dose and the way in which the chemotherapy is given, the cumulative radiation dose and the location of that radiation, complications experienced during therapy and after therapy, the degree of support received, and that means to the child and the family itself during therapy, the degree to which the child and parents are able to cope with the diagnosis and treatment psychologically, and current health-related behaviors. For example, smoking, use of alcohol, and dietary. So essentially, every organ system in the body is a potential late effect, and this is a long but not all-inclusive list of potential late effects that you can read as well as I can. So let's talk about cure. So how do you define cure? A biological cure is continuous complete remission until death from unrelated causes, so that there's no evidence of physical disease. A psychological cure is when somebody accepts having had cancer as a past event and it doesn't continue to interfere with normal development and schooling. And a social cure incorporates the person cured of cancer into society without consideration of past history of cancer and or its treatment. And this is very important because we can't talk about the psychological cure without having a biological cure. And it's impossible to talk about the social cure without the patient accepting him or herself as having had cancer as a normal past event, as a normal part of their life.
So why would we study late effects and sequelae? And I think that this is really an important question. One, we want to really be able to improve what we're doing for our rehabilitation. We want to make sure that we're giving better long-term care. And we want to make sure that new treatment designs include looking out for late effects. So just for a couple examples, this research on neurologic sequelae has made a difference already. In the first study that many of you may know of, the predecessor A9961 and 0331, these are medulloblastoma studies. And in these, we reduced the amount of radiation in an effort to decrease late effects while still maintaining cure. We now use a conformal boost instead of whole brain radiation. We use intensification with chemotherapy with peripheral blood stem cells in order to avoid radiation sometimes. And a very hot topic out there that we may talk about or get questions about, the use of proton beam irradiation. And why? Because kids with brain tumors especially have neurologic deficits. And it's really, sometimes it's about the tumor itself, sometimes it's about the treatment, what we call the direct or indirect of the tumor and its treatment. And these can be from any of the different modalities we use, whether it be chemo, radiation, or surgery, but they're really all equally important. And just some examples. Let's talk about radiation neurotoxicity. Somnolence syndrome, something where kids are sleeping up to 16, 20 hours a day. Inability to walk easily with ataxic gait. And late effects like necrosis of the brain, myelopathy, injury like leukoencephalopathy, premature aging of the blood vessels like vascular injury, neuropsychologic sequelae, learning issues, endocrine issues, bone and teeth issues, eye issues, hearing issues. And I think that one of the hardest ones for us all to deal with, the risk of second cancers. So it's really important we study these things. And one example, this is a very ugly looking picture over here, but we know that from radiation therapy to the brain, it makes it more difficult to acquire new knowledge later on, specifically working memory, and decreased processing speed, and sometimes memory deficits. And all these can be another challenge to the kids. One of the things I think is so important, because there's a positive spin here, is that we are now aware of these issues, and so we can intervene earlier. Awareness leads to better therapies and better outcomes. So I think I've talked about some of these things already. In an effort to move forward, we'll move on to the next slide.
So we know that there are neurocognitive changes that occur during and after therapy for brain tumors, and one of the best ways to identify whether a young person is having issues is through neuropsychological testing. We also advocate for children and young adults to have differences in their learning environments, whether it be in elementary school, high school, or college, by asking for non-timed testing, for tape recording sometimes if people have hearing or difficulty writing with things, and with resource assistance for special help in making sure that everybody knows what their assignments are, that they remember to bring home their homework. Most importantly, there's resources out there for people with special learning needs, including the IDEA, the Individuals with Disabilities in Education Act, and the Section 504 of the Rehabilitation Act of 1973. And we encourage, if you or your child has had issues with learning, to talk with people at your treatment facility to get help to be able to get increased assistance at school. So we're going to move on and talk a little bit about the Childhood Cancer Survivorship Study, which is a huge study run out of St. Jude's, looking at lots and lots of children, adolescents, and young adults, and now actually older adults who are treated for cancer in the United States. And this is specifically a neurology study looking at the timing and incidence of adverse neurologic outcomes in young people treated for brain tumors. We're looking at the effects of age of diagnosis, prior treatments, the late effects that happen earlier on the development of subsequent neurologic toxicities. That was the aim. So this is looking at patients from as early as 1994 up until 2007. And the way in which they gathered data was by self-reported neurologic and neurosensory abnormalities, meaning that there were questionnaires sent out to people who agreed to participate in the study, and they filled out whether or not they were having certain symptoms. It was looking at the time of onset, so the time at which these symptoms occurred, and new symptoms. Looking at the overall incidence, so altogether how many people experience particular side effects, and then use complicated statistics to look at late effects. And they were all looked at 5 years after diagnosis. So this is a graph showing the most common neurologic outcomes, including coordination problems like Dr. Goldman was speaking about with difficulty walking, seizures, and motor impairment. And as you can see, they get more frequent the more years from the diagnosis. So unfortunately, having a brain tumor is a gift that keeps on giving. So this is looking at hearing and looking at deafness and hearing loss, tinnitus or ringing in the ears, and dizziness and vertigo. And again, we see that it continues to increase over time since cancer diagnosis.
And talking specifically about hearing loss, I think it's just like everything else that Dr. Itchik just showed you. And what it really tells us is we need to be involved in late effects programs because you have to have continuous follow-up to look for these symptoms. But speaking something close to my heart, hearing loss, about half of our kids who get cisplatin or high-dose carboplatin will get some hearing loss. Radiation itself will give hearing loss to a percentage of patients. And it's only seen in the high frequency, sometimes out of normal range speeches. But consequences can be communication difficulties, difficulty in a noisy environment, difficulty with consonants. And when you think about it, we've talked about some of the straight neurologic brain neurocognitive toxicity. Now if you make a situation where hearing is difficult, it's like one extra layer that a child has to deal with. So once again, awareness is critical. Follow-up is critical. And here's a standard audiogram. And what this shows is before the circles, some cisplatin, some hearing loss in this 4,040 decibel range, and that the more platinum we give, the more it shows. Now I think for many of the parents that I see, they get this kind of a scattergram when they come to clinic. What we really should give you is this scattergram on that same scale where we see difficulties, where a phone ringing, a piano playing. If you had hearing loss down here, you may not be able to hear an airplane going right over your head or a drum set being played. But if you remember from the previous slide, this is the area where we have common hearing loss, where people can have difficulty determining between the sh, sh sounds, the g sounds. And this can be an educational roadblock. But we can do something about this. We can use constant surveillance. We can have hearing aids. We can make sure the kids have preferential seating. We can make sure the environment's correct. There's something called an FM system, where a teacher will wear a microphone that will go directly to that child wherever they sit in the room, so they don't have to sit in the front if they don't want to. And also we need to make sure that the epidemic of hearing loss that's happening to teens and young adults from earphones, loud music. I really sound old right now, don't I? So all these things that we try to avoid, those environmental factors for our family members and the patients we follow. And this is just an example of some new work that's being done looking at protectants such as amifostine, which in the past have been used to protect kidneys. And it helps that in some studies it may show that it's going to decrease some more of the hearing loss. So changes on the way. This talk is still supposed to be focusing, though, on what people have already been through. But I want you to know the future is going to be brighter.
Right. And so as Dr. Bowman said, we really encourage that patients are followed up in comprehensive survivorship clinics because these clinics are experts at following all of these different side effects that can happen. And there are routine screenings that happen in those clinics. So on to the lungs. So there are certain chemotherapy medications we know that cause pulmonary effects, like bleomycin, which is often used in different types of tumors, but busulfan for stem cell transplants, VCNU and CCNU, all common with brain tumors, can cause pulmonary effects. And those effects are likely pulmonary fibrosis, meaning that the lungs are unable to expand and contract the way that they're supposed to, which leads to a restrictive pattern of lung disease. The way that we screen for these things is by doing chest x-rays to take a look at the lungs themselves, but also by pulmonary function tests to see what the ability of the lung to comply with breathing is. Interventions that we can do after the effects have been made or have been detected are counseling people to stop smoking if they're smoking and encourage people not to start smoking if they haven't. Make sure that if a patient or a young person is getting anesthesia, that certain precautions are taken, and sometimes medications such as albuterol. We know that brain tumors can cause disruption in endocrine function, and sometimes it's from the tumor itself and sometimes it's from the therapies that are received. And the ways in which we see these effects are on growth, on the function of the thyroid, and on fertility, as well as other things. So thyroid abnormalities are often caused by radiation therapy, and that radiation therapy either to the brain causing a problem with the hypothalamic pituitary axis, or the head and neck, which can hit the thyroid as scatter. It can cause primary or secondary failure of the thyroid, and it can also cause nodules to grow on the thyroid that can either be benign or cancerous. The way that we screen for thyroid abnormalities are, first of all, through doing a thorough history and physical exam, but we also measure the thyroid hormones in the blood. And if we feel any nodules or see anything unusual on thyroid hormones, we can do a thyroid ultrasound. So if there are abnormalities in the thyroid, there's treatment that can happen. Sometimes people need replacement thyroid hormones. Sometimes people need surgery to their thyroids, and sometimes they need radioablation to the thyroid. All of this is fixable. The ways in which thyroid dysfunction can happen again is scatter from radiation therapy. It can be disruption of the pituitary axis from cranial radiation therapy or radiation to the brain. And it can lead to changes in the thyroid that can become cancer. We know that if the thyroid works too hard to produce thyroid hormone, it can cause itself to grow nodules that can ultimately become cancerous. So detection of thyroid dysfunction early is really very important, and replacement thyroid hormone is incredibly important. The ways in which we learn from a history and physical exam about whether somebody's having a problem with the thyroid include asking questions about things like whether they're more tired than usual, whether they're having difficulty learning, do they feel cold, have they stopped growing as well as they were growing before, is there a lot of constipation, is their skin cold or dry, is there a weakness of muscles that didn't used to be there. People also often experience a round, puffy face with very dry skin. So again, evaluation after treatment is key, and it must be routine. So even if you check it once, you must make sure that you continue to check thyroid hormones to make sure that they are working appropriately. And there are lots of people who live life with hypothyroidism or decreased thyroid hormone. There's an article in the journal Clinical Endocrinology and Metabolism that showed about 50% of patients who had had craniospinal irradiation had a subtle hypothyroidism, so perhaps without symptoms. 92% of those patients had central hypothyroidism, meaning from the thyroid itself, and 27% had mixed hypothyroidism, which would have been undiagnosed if there hadn't been testing at baseline, so before they had changes. Let's talk a little bit about growth now. We know that there are effects on growth from therapy for brain tumors. Radiation can cause effects, and the effects that people experience include growth hormone deficiency, precocious puberty, meaning going into puberty at a young age, and short stature. So as we all know, being very, very short can have tremendous psychosocial and emotional consequences. And I know you can't see this, but I happen to be a pretty short person, and I promise you it gets in the way sometimes. It can be affected by hormonal effects, and there can be direct effects of therapy that cause the short stature. We know that growth hormone replacement is important, but in the past it's been really controversial because there was some concern that giving growth hormone to people would increase the risk of a relapse of the disease or a secondary malignancy. We no longer believe that that is true. We know that when growth hormone deficiency starts in childhood, it can lead to short stature, but in addition to that, it can change the walls of the heart, and it can make the heart less able to respond to exercise, so unable to pump blood quickly and strongly to the rest of the body during exercise. We know that giving growth hormone replacement not only until a child has finished their growth curve, but also through adulthood can help with lipid profiles. So we know that metabolic syndrome is common in survivors of pediatric cancer. It can decrease fibrinogen levels, which can lead to blood clots. Increased fibrinogen levels can lead to blood clots, and it can continue to increase the function of the heart. So what's the radiation effect on vertebral height loss? So we know that spinal radiotherapy changes the height loss based on age. So if you are a 1-year-old at the time of your radiation therapy, you can lose up to 9 centimeters of vertical growth. At the age of 5 years at the time of radiation therapy, 7 centimeters, and even at 10 years old, 5.5 centimeters of vertical growth. We believe that proton beam may help to decrease the vertebral height loss because scatter is different. So there's also growth that happens too early, and it leads to decreased amount of growth. So precocious puberty is the appearance of physical signs of puberty prior to age 8 in boys and age 9 in girls. It can be due to a variety of things, including the tumor itself, surgery, and radiation. It happens more frequently in females, and some start puberty at a normal age but progress rapidly. So surveillance, again, is the most important thing we can do. We stage people by physical exam, looking at growth and development of secondary sexual characteristics and hair. We test hormones in the blood. We can look at bone age by x-rays. And we can treat this condition with hormone analogs to block continued hormone development and growth hormone so that people continue to grow to the point that they're supposed to grow. Growth hormone therapy can increase the height, and it only works if those bones are still able to grow. So we have to look on an x-ray and make sure that the ends of the bones are not fused, so there's the potential for growth. A permanent loss of growth potential in the spine means that your sitting height is too short, and so you have long arms and legs and a short torso. And the later you start replacing growth hormone, the less time it has to work. So we really try and start screening very early for these things. So this is a little pictorial about growth hormone replacement and therapy in children with medulloblastoma. So medulloblastoma, as we know, is the 11th biggest brain tumor. Oh, this is from the 11 biggest brain tumor programs in North America. So that's where this data is from. This is compiled from kids who are off therapy at least 5 years and were treated with growth hormone prior to the age of 15. It looked at the growth hormone usage and the time to starting therapy, and it matched the recurrence of tumor rates using growth hormone versus no growth hormone. And so if you look at the years post-therapy, and the probability of a recurrence, there's what?
No difference.
There's no difference at all. And if you look at the growth, with no growth hormone therapy and growth hormone therapy, you can see that kids who got growth hormone therapy were able to grow better than their peers who did not get growth hormone therapy. So again, we believe that using growth hormone therapy in children is important. So again, no difference in recurrence rate or new tumors. Gonadal failure or fertility. So we know that high-dose cyclophosphamide chemotherapy medication can cause gonadal failure, particularly in boys. We know that radiation to the spine and the lower abdomen and pelvis can cause infertility. We know that surgery involving the gonads can impair fertility. We also know that of all of the kids that we treat, the prepubertal girls are the ones who preserve their fertility throughout therapy most commonly. So radiation to the brain also can cause premature menopause, primary amenorrhea, meaning that girls don't get their periods, and in boys, low testosterone. So what are the interventions we can do? Well, at this point, really prevention is the most important thing. And so we've been talking a lot in the adolescent and young adult community about preserving fertility prior to starting chemotherapy. And if it's not emergent to start chemotherapy or radiation therapy, the push is now to preserve fertility by collecting semen from boys who can do it, can produce a sperm sample, or preserving ovarian and testicular tissue in order to be replaced after chemotherapy and radiation is done to allow children to have reproductive potential. We can also use hormone replacement therapy and other reproductive technology. We know that if particularly in girls, if the sex hormones are not working, it has an effect on bone health. And these girls will need calcium and vitamin D supplements like women who have gone through menopause. So there are familial cancer syndromes, and outside of this particular population, there is no increased risk for children who have had some sort of a tumor to have babies. It is not more likely for a child with a brain tumor to have a child for a brain tumor than it was for their parents to have them. There are large studies regarding this situation in leukemia, and there are smaller studies that have been done in solid tumors and brain tumors. So in addition, the offspring from patients of different types of tumors have no obvious increase in congenital malformations or illnesses. So even though it's scary to think about, it is not more likely for a young person with a brain tumor to give birth to somebody who has any kind of a problem. So again, we talked a little bit about fertility preservation. We covered these things. We're happy to answer questions about it when we open up for questions. So what about second malignancies? It's very hard as an oncologist to talk to a family about treating their child's cancer and then say, oh, and by the way, some of our therapy could cause cancer in and of itself. Both radiation and chemotherapy can contribute to the risk of a secondary malignancy, and this is part of the reason that we want long-term surveillance in all of our patients, whether in an oncology or neuro-oncology clinic or in a survivorship clinic, just so that we can watch out for this lightning striking twice. There are many radiation-induced secondary tumors, including meningiomas, glioblastomas, and osteosarcomas. For chemotherapy, the most likely secondary malignancy is a form of leukemia. So again, here are the different types. Again, we had talked about thyroid carcinomas. In addition, if you've experienced radiation, there are skin cancers and breast cancers, depending on where the radiation field was. So this is a look by Sick Kids, which is a hospital in Toronto, looking at secondary tumors following radiation for medulloblastoma. It looked at 200 plus kids who were treated from 1985 to 1994. And in that population, there were 8 secondary tumors in 7 kids. Of the kids who got a secondary tumor, 4 out of 7 died of their tumors. 3 of them were leukemias, and 2 received chemotherapy. So the cumulative rate of secondary malignancies in this population was 20%. But overall, at 30 years post-diagnosis, only 10% of patients had had an issue. So we wanted to talk a little bit about direct central nervous system toxicity.
You know, this is, again, to me, one of the things that is so important that kids come and be followed. because we know that the surgery, the tumor, radiation, and chemotherapy can have an effect on the central nervous system. And we worry about people having cerebrovascular disease or being at risk for stroke. We can see this induced from radiation, and it happens usually between 2 and 20 years post-radiation, with a very common time about 5 or so years out, 8 years out. This is really kind of like taking the blood vessels and having them age quicker. And so anytime we see a sign of a transient ischemia attack, stuttering of the words, loss of memory, transient weakness, we have to take this really seriously, and you need to be seen by your physician or have your child seen by your physician immediately. We know that brain tumors, patients who have survived a brain tumor are at increased risk of late strokes. And we see that one thing that's most associated is higher dose cranial radiation, where we're trying to avoid this in medulloblastoma, but for gliomas and other tumors like craniopharyngiomas and ependymomas, we routinely give doses over 30 gray. And I think without bogging you down in the data, it shows that there's a cumulative incidence that's different between a patient having a brain tumor and having a brain tumor and cranial radiation. And you can see here, right, there's an example. So this is very important because, as we know, as the years go on, we still need to be vigilant. Now, when we have this talk, I was thinking, oh my God, we must be scaring people left and right about the future, and that's not the point. In fact, most people do fine. But this is a reason that we have to have continued surveillance. And as our patients survive and grow, there now is a problem where there are many adult physicians who are not aware of some of these concerns. And that's why transition clinics that Dr. Raychek is running and survivor clinics are vastly important to your child and your future. Intellectual outcome, we know that the location of the tumor is extremely important. We know patients with posterior fossa tumors do better than those who in supratentorial, meaning in the front of the brain or the top of the brain is a little more difficult for some of the outcomes. We know that lesions that are deep in the brain are at increased risk of having some intellectual problems even prior to any of the therapies themselves. So the tumor itself can cause intellectual problems. The radiation can cause some neurocognitive problems. And we've done a lot of changes in our protocols to try to be aware of this and maintain survival rates. And here's an old study, but I think a really critical study, and a little bit of history here. For any families there that have a child who had medulloblastoma, we talk about standard radiation and reduced dose radiation. And when I started my career, standard radiation was 3,600 rads to the entire craniospinal axis, and reduced was 23. And there was a study that just said, is it safe to reduce this radiation on kids as opposed to giving chemotherapy at full dose or giving chemotherapy with reduced radiation. So this study, which actually didn't accrue really well because people were unwilling to have their child randomized without the chemotherapy, still gave us some important data. And they looked at kids who were tested 6 to 10 years post-treatment for their schooling and their intellectual outcome. They looked at their quality of life, and they stratified them when they were treated before age 9 or after age 9. And they had some health-related quality of life issues in all the patients at large. Very few to the point of where they couldn't take care of themselves, but most still had some issues. And this hard-to-read slide, the take-home point is those patients who were younger, less than 9, who were able to get reduced radiation, did better in their spelling and reading scores, these IQ scores, as compared to those who were younger who got the higher dose. But as you get older and the brain is more mature, you can see, though there's a difference, it's not as significant. And I think this is an important piece of information.
Okay, now we're going to go on to talk a little bit about cerebellar mutism, which is a scary consequence of having a brain tumor and is seen at the beginning of therapy, usually postoperatively for a brain tumor. It usually starts about 6 to 72 hours after the surgery happens, and it can be seen starting with axial hypotonia, meaning some weakness in sitting and difficulty walking and sort of wobbling back and back, changes in emotion like being upset, happy, and changing very quickly, and some difficulty in making sure that you're saying the right thing. This in red under here, you can see a quote by Dr. Robin Humphries describing the onset of cerebellar mutism. So what does the cerebellum do? It's involved in higher order cognitive functions. So it's very important in thinking and abstract concepts. It helps in early detection and ability to learn from your errors. So if you do something wrong, you learn not to do it again. And it helps other areas of the brain perform functions more efficiently. Without the cerebellar input, motor and thinking performance is slower, inaccurate, difficult, and changeable. So who gets cerebellar mutism syndrome? Most kids involve kids. There are reports, however, of cerebellar mutism in older patients. It happens most commonly in kids who've had a brain tumor at the back of their brain. So medulloblastoma is the most common diagnosis we see it in, followed by ependymoma, choroid plexus tumors, rhabdoid tumors, and it's rare in astrocytomas. It's often tumors that are in the middle of the brain, meaning sort of along the spinal axis. There are other people who get cerebellar mutism syndrome, kids who've had trauma to the brain, kids who've had infection or bleeding in their brain, kids who've had a blood clot in their brain, and kids who have abnormal blood vessels. So the reason we're talking about this now is that we know that if a child has cerebellar mutism syndrome, it is associated later on with worse global neurocognitive outcomes. So as you can see in this graph here, with the orange being the cerebellar mutism negative kids and the blue being the cerebellar mutism positive kids, that IQ is lower after having suffered cerebellar mutism. Oops, sorry. In addition, special education services were more frequently needed. So the blue here is kids who had had cerebellar mutism, and the red is kids who had not had cerebellar mutism. And it's a doubling of number of people who needed special education services. So, importantly, for this talk, there's research going on looking at neurocognitive interventions to help prevent these long-term effects. We can do cognitive assessments, and there is a new protocol or website and a bunch of interventions called CogState. There's computerized cognitive training through CogMed. There's pharmacotherapy, so different medications can be given to increase alertness and the ability to concentrate.
And we also have now written into all our protocols neurocognitive assessments, both during the therapy and afterwards, so that we can increase awareness and have early intervention. And one example of an early intervention trial, and again, with not promoting any particular, just to show you that they're out there, is a study of modafinil, which has been tried to improve neurocognitive deficits by increasing awareness and working memory. And this is just not to go on the details of this, but to show that we have a trial now that's ongoing, that not only during the time to have the therapy being given, I'm sorry, I got paged, to make sure that this is a kept change for the positive in the future. And let's talk a little bit about psychosocial late effects.
So we know that having cancer in general predisposes you to have some psychosocial late effects because there's a part of life that gets skipped while you're getting therapy. There's been a lot of literature about post-traumatic stress disorder in patients who have had cancer as a direct result of cancer being a life-altering event. The fact that kids go through lots of painful procedures during their therapy, that the fact that kids no longer have control over themselves or control over what's happening to them and what's happening to their family. This is experienced as an immediate consequence, but may also feel like a lifelong consequence as secondary effects come up. There's a separation from the family, friends, what is safe and known during therapy, and this post-traumatic stress can impact both parents and a patient. Most interesting to me is that most people, when surveyed at least a year post-cancer therapy, report that although they may have had symptoms of post-traumatic stress during treatment, they feel that they've had what's known as post-traumatic growth, meaning a clarification of what's important in life, of who is very important to have relationships with in life, and other things that they see as beneficial ultimately as a result of having had cancer. Additionally, having cancer can change your life trajectory because, especially if you're a teenager and you're working on separating from your family and becoming more independent, being ill makes you become more dependent on your family. It can also change social situations. Young adults who are living on their own may have to come back and live with their families for a period of time during therapy, and can change both current employment and the ability to be employed in the future. So again, it's not all bad. Psychosocial research has shown that survivors' worries and anxieties are not actually greater than age-matched controls, and are actually survivors are actually less focused on their health than people their own age who have not undergone therapy for cancer. And despite the fact that many late effects can happen in kids who've had brain tumors, these children and adults are mostly satisfied and happy with their lives. And again, most report post-traumatic growth as a result of their cancer therapy. What specific psychosocial effects do we look out for in adolescents and young adults? So as if we can all think back to being a teenager, it's really important to be liked and accepted by your peers. Cancer therapy changes that. It pulls you away from your peers and isolates you during therapy, and sometimes because of changes that are associated with therapy. Again, cancer diagnosis and treatment can make your self-confidence and your self-image and self-esteem change because of those physical changes and physical abilities that change during treatment. And additionally, as I said before, that life task of separation and individuation that's so crucial at this time of life can be changed by the diagnosis and treatment. And because they're working towards independence, young adults and adolescents when they become more dependent again on their family, they feel infantilized or regressed. These are really important when cognitive and physical abilities are changed by treatment. And again, in this age group, fertility issues are of utmost importance. What about relationship issues? So isolation from peers at this crucial point can affect somebody's long-term ability to form relationships. There are many relationships that may end during high school due to the stress of illness because peers can't cope with the thought of somebody their age having cancer. Changes in somebody's body image can then affect their sexual development and sexual relations both in the present and later on in life. And we know that sexual drive, sexual function, and fertility may be altered by treatment itself. This is a confusing picture about different factors that have been identified that affect marriage and brain tumor survivors. So there's been a lot of data regarding how many survivors of pediatric brain tumors are married versus their age-matched controlled. And in general, boys who have a lot of neurocognitive challenges are less likely to get married than boys their own age who have not undergone cancer therapy. So what about social skills? We know that development and neurocognitive changes occur because of our therapy, and that may affect social development. Social development may also be changed because parents get so worried about their kids during therapy that they don't set the same limits during therapy that they would have set before, and they don't allow their kids independence and the privileges that they used to have before they were receiving therapy. What about education? Education and the outcome of education is really dependent on somebody's neurocognitive status. So survivors of brain tumors are more likely to have special education needs because of the side effects of therapy, and are slightly less likely to attend college. However, with early intervention at the time of onset of these neurocognitive changes, survivors of brain tumors certainly can go on and get an education and do what they dream of doing. What about employment? Again, dependent on somebody's neurocognitive ability. Survivors of brain tumors are more likely to be unemployed, but this is more related to their physical abilities or disabilities necessarily than their neurocognitive ability. So we've alluded to transition of care for adolescents and young adults, and this is close to the end of our talk. And I just wanted to spend a moment talking about change of care as people age. So we know that transition to adult care is difficult for anybody who has a chronic health problem. It's a process over time, and right now we define it as a purposeful movement of the AYA, or adolescent or young adult, from the pediatric health system to the adult setting. Our goal is for the adolescent/young adult to achieve successful engagement in the adult system so that they can receive developmentally and medically appropriate care. And we know that this transition should be coordinated. It should be centered on a family, a particular family itself, and it should be planned. We know that there are several stages of transition. Initially, we talk about envisioning a future. So we start talking about future planning. So that gives hope that there is going to be a future, but also gives time to adjust to the changes. And we start this transition process way before it actually occurs. There's then the age of responsibility where the survivor takes over some autonomy in their own care. So whereas maybe parents have been making most decisions, the survivor themselves takes over. And then there's the age of transition. It's divided into adolescence and young adulthood, and the tasks change depending on where you are in this continuum. And it gives increasing levels of decision-making ability with regards to healthcare to the survivor. What are the barriers to this? Change is hard. If you've been treated by people for years and years, you don't want to leave them. And you may feel abandoned once you leave them. It also has a change in a role for the adolescent or young adult, which changes dependence on parents' help to decision-making on the adolescent or young adult's own behalf. Sometimes adult survivors or even people as young as 19 no longer have health insurance, which makes transition difficult. It's also hard to find an appropriate medical home for adult survivors of pediatric, adolescent, or young adult cancer. We know that adult providers are not used to taking care of survivors. As more and more survivors are in the population, they will need better education about late effects. However, at this point, we know that it requires multidisciplinary collaboration and communication, which is, again, why we encourage everybody to be followed in a survivorship clinic that can coordinate this transition to adult care. So what can the survivor do to maintain health? The same thing we can all do. Exercise regularly, get enough sleep, eat good foods, drink alcohol in moderation, don't smoke, and wear sunscreen.
I think we have to talk about the future. We know that multidisciplinary teams are focusing on survivors and their issues. We're using quality of life assessments now to improve our ability to understand this. We're writing them into new studies. We're getting new therapies. I want to leave us time for questions. We have things that we're doing in hearing, growth, fatigue, and endocrine, and intellect. We know that psychosocial research has shown survivors' worries and anxieties are no greater than age-matched controls, and actually they're more focused on their health than some of the silly things people think about. And in conclusion, these late effects are real. They are substantial. Our new treatments are aimed not only at survival, but to minimize late effects. Late effects need to be dealt with by multidisciplinary teams. Evaluation and early intervention are key, but despite this, patients are satisfied and happy with their lives. So new awareness leads to better preparation and coping, new research to understand risk and interventions, new multidisciplinary emphasis to improve quality of life, with more research and advocacy. And I think the ABTA is one that really shows us they've been doing advocacy for so many years now that we can change the future for survivors of childhood brain tumor. Thank you, and we'll be happy to take questions.
Thank you both so much for the presentation. Dr. Goldman and Dr. Rychek will now be taking questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. We do have a couple questions that have come in. The first one, which chemotherapies are cyclophosphamide?
It's also called Cytoxan. It's an alkylating agent, and it's used in many of the brain tumors we treat.
Okay. Our next question is, are there any interventions that have been found helpful for young adult survivors, specifically to cope with stress and anxiety as they move further into survivorship? And specific interventions they're looking for.
So we know that peer support is very important, so peer support groups are helpful. Things like meditation and yoga, and even sometimes talking therapy can be helpful to manage stress as a young adult moves into adulthood, as a survivor moves into adulthood.
I think it's really important that those people seek a therapeutic group or an individual therapist to help them with this coping.
Great. And how often do you think survivors should be seen in a survivorship clinic?
So the standard of care in comprehensive multidisciplinary survivorship clinics is 1 time per year.
But it does depend on the individual's needs. And so there are some survivors, though, once a year is indicated. They may have specific needs that need following that and may be more frequent. So we wouldn't want to limit it to once a year. I think one of the things that makes it difficult in brain tumor, survivors of brain tumor, is that the diseases have different risk periods. So a child with an ependymoma may have a recurrence later. So is it really 2 years off therapy where they transition into a late effects clinic, or someone with an astrocytoma or a medulloblastoma? And I think the real answer is that's why you need a coordination between your neuro-oncologist, your neurosurgeon, your neurologist, and your late effects specialist. And if we can work as a collaborative team, we can make sure we're looking at the awesome and important issues of quality of life and late effects while still doing our surveillance screening for tumor recurrence.
Additionally, many people need other services involved, so if there are endocrine problems that have occurred as a result of therapy, it does not mean that you see your endocrinologist just once a year or your kidney specialist once a year, but there is a coordination of care that happens so that everybody is being taken care of based on their particular disease and their special needs.
Great. Another question, are there any physical signs on brain imaging that would indicate cognitive deficits?
So that's a great question. I wish I would have, I was going to ask that one myself. You know, this is an extensive field of research, and even ourselves here at Children have studies that are ongoing, looking at changes in white matter and track changes and associate that. We have a study that's tracking changes on MRI scan over time as we follow our patients. So this is a very, very hot field. This is developing, and in the very near future, I think that this will lead to some potential areas where we will be able to identify and have early interventions. So this is a developing field, and yes, we are finding areas.
Okay, another question. We had a few questions regarding whether or not to disclose your diagnosis to employers and whether you have any recommendations for that.
I think that is a personal decision. I think that people's medical health information is private, and if an individual believes that their employer needs to know about their medical history, then it's perfectly appropriate to disclose that. There are always concerns about discrimination based on prior medical conditions, and in fact, we've had some slides, and I think Dr. Goldman is pulling them up. There are resources, so if somebody disclosed that they had had a brain tumor to an employer, there are resources if they felt like they were being discriminated against that can help with that, and those are currently on the screen, I believe.
Great. That's a great resource for patients and families.
Plus, you're all thinking, how many slides could they possibly have had?
No, they're all good. They're all good. Another question, what are some of the late effects of viscosine and carboplatin?
So again, carboplatin is a platinating agent, a non-classical alkylating agent, and one of the ones we mentioned on this earlier slides were hearing loss, not near as much as can be. Go ahead.
It can also cause difficulties with kidney function, both during therapy and after therapy.
It can be marrow-suppressive, but that's why when children get, and I'm guessing this is asked by a parent with a low-grade glioma, a parent of a child with low-grade glioma, because you get carbo-vinc together. And that's why you're getting those blood tests so frequently during the time of administration. Vincristine can cause neuropathies, peripheral neuropathies, foot drop, constipation, burn if it gets out of into the tissue. And most of those we say are temporary. Unfortunately, I think when I'm a patient, temporary means I go to bed and tomorrow morning it's better. In the medical world, sometimes temporary means not permanent, but can be a long period of time. And if we're not careful with our dosing, we can have people have significant and prolonged peripheral neuropathies like a foot drop, etc. So again, I've been doing this a long time. I've never, ever lost my respect for the seriousness and the potential toxicities of these chemotherapeutic agents. And it must make people crazy when they come so frequently for their treatments. Why are they always getting examined? Why are they always getting labs? Why are they always getting talked to? And it's because we have to be very careful how we administer the meds to prevent as much as possible these late effects.
Great. We did have a couple questions. Patients were surprised by the pulmonary effects you talked about and wanted a little bit more information on the effects on the lungs.
So it is easy to say that busulfan is not used as much as it used to be in pediatric brain tumors, and maybe we should have left those out. But it was at one point a common therapy that was included in high-dose chemotherapy with stem cell rescue for kids with brain tumors. And it's under those regimens where the most pulmonary difficulties would occur. When we do craniospinal radiation, where we're giving higher doses and not controlling the beam as much, there was more of a radiation effect. And again, even with CCNU, the nitrosoureas, that is a risk, but it is not commonly seen. But again, we tried to make this talk to people who have been long-term survivors that might have had therapies given a distant time ago. So for many of you, PFTs may not be a routine function. It depends on the history and the amount of the drug you got. But once again, we want to make sure people are aware of the potential toxicities to all the different organ systems.
Great, I think that's very helpful. We had a couple questions come in about just coping with the long-term impact of this diagnosis on their personality and social skills. And I know you had a couple slides on that, but if you could just elaborate a little bit more.
So I think that's really individually based. Some of it is based on where the tumor is, what the therapy was, and what the particular changes are. Again, as we said earlier, I think support is crucial both during therapy and after therapy, and trying to get kids back to the business of living as much as possible a regular life, the life that they were living before their diagnosis, is really helpful.
I want to add, I think that here's where I believe we really can make an impact. And I think this is dependent on, and it's really important that the medical team caring for your child or you as a survivor, as well as your family, yourself, and your community, make sure that we don't have people become isolated, that we don't focus on what disabilities may be small or significant, and that we maintain a lifestyle that is a mainstreamed lifestyle. I can't tell you, I've been doing this a long time, and some of this is not based on studies, but patients and families who continue to interact in a normal manner, who have interactions with friends and family, really will help them in the long run to cope and move forward. That's easy to say until you're the person in the situation where you spend much of your time coming to the hospital, or you don't feel that you can go to school as easily. So it's easy for me to make these comments. I realize that they're complex. But as much as possible, we believe during the treatment, you don't want to be someone who's a medulloblastoma. You want to be a child who may happen to have a medulloblastoma. We are not treating tumors. We are treating children with tumors. And as long as we continue to make sure that we push forward to help children to understand, and young adolescents and adults, that this is a part of their life but not the defining moment in life, that may help them to cope. And then all the resources that Jen has talked about, I think, are very important in helping them cope with their disease.
That's fantastic, and I think something that everyone really needs reminders and reassurance for, so thank you for that comment. We have time for just one more question, and it's regarding any studies on young adults for sexuality and development in the survivorship stage, if you're aware of any, or if you have any advice for that.
I'm going to have to take a guess at what is meant by sexuality, but again, it depends on the person's particular situation. There are some studies out of the Childhood Cancer Survivorship Study looking at sexuality, sexual interactions, marriage, having children, and things like that. In the survivorship population as a whole, I'm not aware of any studies, particularly with regard to the brain tumor population, but again, there's a spectrum, there's a continuum of function that happens because of a person's neurocognitive abilities. I think as we continue to have more people survive different diseases, all aspects of psychosocial functioning, including sexual function, will be looked at. with this rich population.
I think the bottom line is we learn from our patients and their families, and there is no topic that's taboo that we shouldn't try to study so that we can give you information so that people can move forward with their lives.
Great. This has been wonderful. That's all the time we have for today. I just want to thank you all for joining us, and thanks once again to Dr. Goldman and Dr. Rychek. We're just going to pause for just a moment to stop our recording.